Hello, my name is Dr. Melanie Bourgeot. I'm a fourth-year pathology resident at Emory University, and in this video, I'm going to be going over another challenging soft tissue pathology case for new trainees. If you would like to view these cases for yourself, you can find links to the digital slides in the video description. This is a painless, slow-growing mass on the finger of a 46-year-old female. At low power, we can see this is a multilobulated lesion with areas of dense fibrosis. Moving to higher power, we can see that these lobules are composed of sheets of epithelioid to plasmacytoid cells with rounded nuclei, prominent nucleoli, and a moderate amount of amphiphilic cytoplasm. Focal hemosiderin deposition is present, and the background is variably collagenous. In addition, there are also scattered multinucleated giant cells. Lastly, there are also areas composed predominantly of foamy histiocytes, like this area right here. This is an example of localized tenosynovial giant cell tumor, a benign soft tissue neoplasm which, as the name suggests, arises from the synovium and involves the tendon sheath near the small joints, particularly the fingers. They can occur over a wide age range, but are most common in the 3rd and 4th decade, with a female predominance. Characteristic features include multilobulated growth, dense fibrosis, foamy histiocytes, and hemosiderin deposition. The giant cells themselves are not neoplastic, and are recruited by the mononuclear tumor cells. Mitotic activity can be relatively high, but this on its own should not be concerning for malignant transformation. In this case, you could see that the giant cells were not numerous, and there was minimal hemosiderin deposition. To give you a better sense of the morphologic spectrum of this tumor, I'm going to show a couple more examples. In this example, we still have multilobulated growth and dense fibrosis. However, even at low power, you can see that the giant cells are larger and more numerous than the previous example. In this example, you can see cleft-like spaces forming pseudopapillary type structures. This is another feature that can be seen in tenosynovial giant cell tumor. In addition, there is abundant hemosiderin deposition. Often, the hemosiderin likes to accumulate in mononuclear tumor cells around the periphery. These are referred to as ladybug or ladybird cells. So far, I've only talked about localized tenosynovial giant cell tumor. However, there is also a diffuse type. This type commonly arises in the large joints and carries a risk of significant morbidity, since negative margins can be difficult to obtain. Both the localized and diffuse types of tenosynovial giant cell tumor have balanced translocations involving the chromosomal region of 1p13, which includes the CSF1 gene. Overexpression of CSF1 by tumor cells is what is thought to cause the recruitment of osteoclast-like giant cells. There are also giant cell tumors arising in the soft tissue and bone, and I'm going to talk a little bit about those. Giant cell tumor of soft tissue arises in the superficial soft tissues, most commonly in the arm, thigh, and calf. They may also have a rim of peripheral ossification, so myositis ossificans, which I talked about in a previous video, may enter the differential based on the imaging findings. These lesions do not have any characteristic molecular alterations. Giant cell tumor of bone usually arises in the epiphyseal region of long bones, but may extend into the adjacent soft tissues. However, this is not a feature of malignancy for these lesions. These tumors also have a characteristic mutation in histone H3.3, with over 90% having the G34W point mutation. And that's all I have for now. If you would like to learn more about giant cell tumor of bone, I provided a link to a thread I posted on Twitter a while back in the video description. You can also check out my Pathology Mega Index, which is a list of all my educational posts and videos. Please like and subscribe and stay tuned for my next video. Thanks for watching.